So I'm going to talk about considerations and things to be on guard about during the hospitalization, and as an overview here, and then we'll try to break it down piece by piece. And I also want people to know that in your booklets, I'm going to mention a few medications in particular, and I know people don't want to miss those particular medications, but in your booklet under educational materials, I summarize it, or we summarize it. So you don't have to write anything down. It's there, it's in there, but we'll just go over the big broad strokes here, and if you've got a written record of it in your pamphlets under educational materials. So don't worry about that. Okay. So we're going to talk about medication schedule, medications to avoid and limit, the sense that early mobilization should be supported and you can participate in it as best you can, and the awareness that confusion and paranoid feelings may occur, and there are things that can be done about that. And the last one, which I think is sort of simple but useful, is that if all else fails and there isn't an immediate reason why you need to be in the hospital, leave. Because a lot gets better in terms of being oriented and understanding the world once you're out of the hospital and you get a night or two of good night's sleep. Okay. All right, so medications, the timing of medications. Hospitals are built really around the idea that you're taking medications on a certain schedule that's every 6 hours or every 8 hours. That's their usual routine of giving medications. And some parts of a hospital are more amenable to changes than others. So this is something that you have to work out in the hospital that you're in. But if possible, and as nicely as you can ask, it would be good to talk over with the admitting doctor, can you try to keep on the schedule that you normally take your medications? And that's not 3 times a day with your medications. It's at 8 o'clock, 12 o'clock, 5 p.m., whatever it is, the times, and not every 6 hours, because you know that the timing makes a difference to you, okay? And many hospitals don't understand that the timing makes as much difference. I think there are even some hospitals where it's possible that, under the guidance of a caregiver, you might be able to have someone to remind the nursing to keep things on schedule. But I think the best is if the doctor writes it in the notes or the orders that to keep your medications at certain times of the day. This will be disrupted sometimes because you're going to be off at a test or something like that. But if it's kept to the time of the day, I think you do a little bit better. I know it's not possible in all hospitals, though. Okay. The other general strategy is that your Parkinson's disease medication should be continued as late as possible before any planned procedure. Just like sometimes they allow you to take your blood pressure medicines the morning of the operation, you can ask, can I also take my Parkinson's disease medications at that time? And then also making it clear to the team that's taking care of you that you'd like to resume the medications as soon as it's safe to take your medications. It's also possible for people who are prone to hallucinations to temporarily reduce certain medications, such as amantadine or a dopamine agonist, if they're really quite prone to hallucinations, because these medications are more likely to cause these kinds of problems. Okay, so this may be hard to read, and it's meant to be. So there's a gentleman in his bathroom. He's looking in his medicine cabinet, and he's looking to see what he's got here. We've got Allegra, Lunesta, Levitra, Boniva, Avandia, Abrivia, Byetta, Spiriva, Zetia, Lyrica, Viagra, Concerta. So the point here is that we got a lot of medicines. You have a lot of medicines in your medicine cabinet, and the hospital pharmacy has a lot more. We can throw a lot at you, but there's some things that we shouldn't throw at people with Parkinson's disease, and not all hospital physicians are attuned to that. And so that's what your list in the educational materials on the right side of the binder is all about. I'm going to just talk about that in some detail for a few moments, but you don't have to write it down. In the hospital, people get nauseated. They're nauseated because they have some kind of problem with their GI tract. They are nauseated because they have an illness, on and on. Or post-operatively, they're nauseated. There's certain medications that block dopamine receptors and interfere with the benefit of Parkinson's disease medicines that you shouldn't get. These medications have brand names like Compazine, Reglan, and Thorazine. You should try to avoid taking these. If you take these, you will live, but you'll be slow. And so we just want to avoid that by basically taking them off the list of medications. There are alternatives that can be used, and they're mentioned in the pamphlet. Similarly, for agitation and paranoid feelings, certain medications like Haldol, Thorazine, Risperdal, and Zyprexa can worsen Parkinson's disease symptoms, and they should be avoided as well. There are alternatives. Third group, medications for pain, particularly the opiate medications, can exacerbate disorientation and provoke psychosis and constipation. That doesn't mean you can never take it. It just means that if you're acting really crazy and they're giving you, Vicodin round the clock, that you should put it together and say, maybe it's the Vicodin. My pain's under better control now. Maybe we can ease off this pain medication routine. Okay, and so the last point here is that there are alternatives, Zofran and Kytril, Tygan. Those are names of other antiemetics, and there are other medications that can be used for paranoid behaviors. What else? A number of you are on a class of medications called monoamine oxidase inhibitors. They have the names of Eldepril or Selegiline or Azilect or Rasagiline, and that class of medication has a potential interaction with certain medications. You've been warned about certain things like not taking it with Sudafed, I suspect, but you shouldn't take it with Sudafed. But in the hospital, sometimes they want to treat really bad pain with Demerol, with merperidine, but merperidine or Demerol doesn't get along well with, at least theoretically, with Azilect or Eldepril, so that should be a no-no. Almost considered an allergy for you. Okay, so switching from meds to getting going, if you're planning a hospitalization, you're planning something for your knee, for your hip, for some other body part, it's good to build up, to get some exercise and to strengthen yourself, anticipating that you're going to need to work hard to mobilize after whatever procedure you're getting. And so that's the preparation. But afterwards, after whatever has happened, you need to get up and push yourself harder than you are used to. And you got to think about it sort of as a boot camp or a training for new sport, with observation safely within the hospital. And some people are worried about getting shipped out of the main safe hospital. Think back to that cartoon, the safe hospital, and going to rehabilitation. And I think many of the people in the room who have been hospitalized or have had joint repairs can tell you that their physical therapy was better and they rested better in rehab. And so I think I just want to plant that seed that going to rehab may be a really good option.